Hello and welcome everyone. Today we'll be discussing an important topic, that is how to find the optimal tidal volume in our ARDS patients. So ARDS, since its initial days and the initial days of ventilator, the tidal volumes are set very high, around 12 to 15 ml per kg. But then over the period we learned that there is something called ventilator induced lung injury. So, according to the concepts that were there in that time, in 2000, the ARDS trial was done, which showed 6 ml per kg versus 12 ml per kg had a better outcome. So, the guidelines were like this: we need to set a tidal volume of 6 ml per kg for the predicted body weight and to keep a P plat of less than 30. So this continued for a long time. Then in 2015, the Amato trial showed that the driving pressure, if it is more than 15, it was associated with worse outcomes. So this was something which was dealing again with the compliance of the lungs. Previously, we were focusing solely on the tidal volume that was to be given. So next in 2016, the lung safe trial showed that we give a tidal volume of around 7.6 ml per kg of the predicted body weight and keep a P plat of 23.2. But this covers most of the patient, doesn't necessarily restrict itself to the severely ill patients. So probably that is the reason, because the severe patients were less, the P plats and the tidal volumes are this low. In the 2023 ESICM guidelines, what they do is they have shown that the superiority of the lower tidal volume is not really supported by statistical significance. Comparing 6 against 12 is a large difference, but when we need to understand when should we give 4 or 8, that becomes a trouble. With should I give 4 ml per kg or 6 ml per kg or 8, or for that matter 10? That has not really been shown to be very clearly defined in the literature. So from this point beyond, we should focus on trials which try to find out this correlation between the lung function, that is compliance, versus the tidal volume that we are delivering, and based on that try to make a formula with which we can titrate the tidal volume to minimize the villi. There is a lack of comparative clinical trials of these small tidal volumes versus large. The only single trial was very large difference, that is 6 versus 12. So no clinical studies compare the outcomes of 6 with tidal volume ranging from 7 to 11. We know 12 is bad, but in between we don't know how much more we can go. Recent meta-analysis has shown that the lower tidal volume does not significantly affect the patient's outcome. The analysis included only 3 trials with quite moderate heterogeneity of 61%. Now, there are some issues with the low tidal volume. The first is that some patients who, even though ventilated with a low tidal volume, will show signs of hyperinflation. So, giving a low tidal volume is not necessarily correlating with better outcomes. This is because what we are measuring is the volume of the normal lung, but in ARDS, it is the baby lung. So, even though we are giving a low tidal volume, we cannot say for that particular patient how low is actually low enough. Now, there have been a lot of criticism of this predicted body weight based tidal volume titration, because this clearly can be misleading. It overlooks the proportion of the lungs available for ventilation. As we have discussed, we are not sure what is the proportion of the lung which is actually present. How big is that baby lung? We just assume that it is 6 ml per kg, but it's not necessarily, and it just cannot be possible that it's same for all people. So we need alternative approach. Tidal volume can be scaled to aerated portions of the lung estimate by the compliance of the respiratory system. Driving pressure, that is the tidal volume divided by the compliance of the respiratory system, is more accurate ventilatory predictor of outcome in ARDS compared to the tidal volume. So the findings of the Amato trial was that reduction in the tidal volume favorably affects, and it is mediated by decrease in the delta P. So in those patients where a low tidal volume results in a high delta P, there we may not get the benefits of the low tidal volume. So we should actually target the delta P, that is the driving pressure, looking also the elastic component, that is the compliance of the lung, rather than just the tidal volume. So there are some unresolved questions. Is the driving pressure an indicator of unsafe tidal volume with direct impact on outcomes? What factors influence the compliance and interplay between the tidal volume and the driving pressure? Addressing this issue is important, and it is important to help us in titrating the tidal volume of the patient. So, driving pressure as an indicator of unsafe tidal volume. Driving pressure is proposed as the variable which can stratify the risk of hospital admission. Emulated randomized trial 30 days ventilator mortality was 20%. Absolute reduction by doing this strategy in 30-day ventilator mortality was 1.9% for delta P less than 15, 4.4% reduction if the delta pressure, that is the driving pressure, is less than 10. The greatest impact of the driving pressure is limited on the onset of mechanical ventilation and it is maintained for a longer duration. Influencing factors on the compliance and the tidal volume driving pressure interplay. PEEP is an important factor. Clinically selected PEEP, clinicians select the PEEP, affect the compliance and the interplay, influence the lung volume and the mechanical stress. The chest wall compliance is also important. The elastic component of the chest wall impacts the respiratory compliance. So the chest wall compliance affects the partitioning of the respiratory mechanics from the chest wall from the lungs. So mechanical stress components are the lung volume, which is influenced by the PEEP, that is the lung volume which is present at all times, that is even during the expiration, and partitioning of the respiratory mechanics from the chest wall and the lungs. So trials comparing high and low PEEP did not focus on the limited delta pressure strategy. Studies using physiological guided protocols to set PEEP varied in methodology. Uncontrolled factors affecting the delta pressure and PEEP optimization are the severity and the pattern of the lung injury, the body positioning. So if I give a PEEP setting, say I set an optimal PEEP of 10 for a patient in right up position, it may be totally different in the left up position. Similarly, if I make the patient prone, my PEEP will also change. So my body positioning, which is constantly changed in the ICU, is changing my delta pressure as well as the PEEP optimization. Airway closure, hemodynamic factors are also important. Non-homogeneous distribution of the ventilation is also very crucial. So guidance for the personalized care for the delta pressure and PEEP setting are: we can go for stress index describing changes in the compliance with the tidal inflation, lung imaging techniques, that is electric impedance tomography or CT. With electric impedance tomography, something which we can do at our bedsides, estimating the pleural pressure. This helps in getting more personalized delta, but for this we need esophageal catheters and we need to correlate how much that change actually is correlating with the pleural pressure changes. All these things help us in homogenizing the distribution of the ventilation and regional lung mechanics. So this is a summary of what we have learned till now. How to set the tidal volume in ARDS patient. So initially what you need to do is calculate the predicted body weight. Next, you set the tidal volume at 6 ml per kg. This is what we know till now. But then beyond this, what we need to do is, next what you do is calculate the driving pressure. That is the delta P, that is tidal volume divided by the compliance of the respiratory system. Aim for a driving pressure of less than 15, and ideally it is best if it is less than 10. If it is more than 15, what you need to do is reduce the tidal volume by 0.5 or 1 ml per kg of the predicted body weight. Now reassess the change in the delta pressure or the driving pressure and adjust accordingly. If the delta pressure or the driving pressure is less than 10, then you can increase the tidal volume as well from 0.1 to 1. But then also keep in mind that you have to keep on measuring the delta pressure and do not allow it to go beyond 10. Apart from these factors, if you have more advanced settings, then you can do two things. First is you can optimize the PEEP. You can do that by trying to get the best compliance with the best PEEP and also guide the PEEP based on the hemodynamics and the other guidelines. The next is the optimal ventilation strategy, because the lung is not homogeneous. How will I know that my ventilation is going homogeneous? For that, I need advanced imaging techniques like electrical impedance tomography. Using that, I can optimize my tidal volume and ventilation. Thank you for your patience.